Okay, welcome to the Atorvastatin clinical trial update. Thank you to Dr. Awad and his team for joining us, and thank you to Joanna Jimenez and the Florida Angioma Community Alliance for hosting today. I'm going to hand it over to Joanna, but just before I do, you're going to see some polls tonight, which is something that we haven't done before. So we're going to ask you a few questions over the course of the webinar. It'll be coming in as a poll format. This is new to all of us, so hopefully it'll go smoothly. And then we're just asking if you could answer those questions as we go along. All right, I'm passing it over to you, Joanna. Thanks.
Thank you, Darla. So let me introduce, we have an internationally recognized leader in neurosurgery. He leads a neurovascular surgery program at the University of Chicago. He is recognized as a pioneering and productive scholar. He has educated scores of neurosurgeon trainees and holds prominent editorial responsibilities. He has published more than 350 scholarly papers related to clinical innovation, surgical outcomes, and research. He serves on the U.S. National Council for Neurological Disorders and Stroke and is the founding chairman of the advisory board of Angioma Alliance. We have one of the best doctors in America with us live today, Dr. Awad.
Joanna, thank you. You always make me tickle when you make this introduction. It's very humbling. It also, you could see that Agnieszka and Christina's eyes roll up when you say that. So we're all good. I want to thank all the participants, and we were talking a little bit earlier about how to make this webinar a little bit more engaging so that you guys get more and more out of it as we do it in upcoming versions. And one of the things we came up with is that in addition to giving you the updates and doing the question and answer, we will do some polling to understand who you are, who are joining us, and what may be the main reasons that are making you join us for the webinar, so we can focus on it. And also, Connie and I have been talking about potentially broadening the questions and answers beyond the Atorvastatin trial, so that if you have questions about anything related to research that you have heard about, whether it's zinc or the microbiome or vitamin D or anything else, I think broadening the questions and answers would be good. I want to introduce the two young ladies that you see there with me, Agnieszka Stadnik, who is basically the person who oversees all the regulatory aspects, signs you up in terms of making sure your consent is legal and the data is all being entered on time in the right place. She handles the pharmacy, dispensing the drug, and many aspects of this and other studies. Thank you, Agnieszka, for everything you do. And Christina also is the other wheel that keeps that bicycle going. And Christina is basically your window to our team in a big way, and to all our research studies, the biomarker studies, Atorvastatin and trial readiness, and so forth. So basically, you call when you have a problem, you call when you have a cavernous malformation, you call when you want to ask about a study, and you're likely to hear back from Christina. So those are the people that I depend on among a dozen other researchers who really work with the actual research data, but really the faces are here with you and they will help me answer your questions. So I wanted at the beginning to give you a little update on where we are, and many of you have had questions as to how the COVID-19 pandemic is affecting research in general and this trial in particular. And the first thing is that we had continued to enroll really on schedule, and actually a little bit ahead of schedule in this trial till the COVID pandemic really stopped a lot of people from being able to travel and enroll about 2 weeks ago. I think the last person we enrolled was exactly about 2 weeks ago, I think at the very beginning of the crisis, right?
March 17. Yep.
Yeah, so it's really not that long ago. And that was number what,
36.
36. So basically, our goal was by the end of March to enroll 40 people, which is the halfway mark for the trial. It's a big celebration when you do half of the 80 that you plan to enroll. So Corona got in the way of doing that on time, but we have a long list of you that have called us and that are interested in enrolling, and we have been in touch with you. And we will catch up very quickly with this because, as you know, the trial enrollment allows you to enroll within a year of your bleed. So if you had a bleed in recent weeks or months, we still have a window whereby we can still get you enrolled, and we will be ready to get on board. Meanwhile, we are open for business. So if you have any questions at all about your future eligibility, what you should do in the interim, whether your lesion is more appropriate for surgery rather than the trial, please, call on us. Even though you're stuck at home, we are actually working, and we're working in different ways. Our teams are as busy as ever, and we will accommodate you. We are still doing clinics, both in person and remotely. Of course, for people who are having difficulty traveling, we will do remote visits as needed. We have gotten a number of patients accessed and operated on in the last 2 to 3 weeks for their bleeds, despite the COVID crisis. So we are continuing to work with you. We don't want you to be so afraid that this corona is distancing you from us. You are not distanced from us. We are with you, and we will pick up the pace as soon as everybody is able to resume normal life. A question has also come up about the follow-ups that are scheduled. As you know, for the trial, you are supposed to follow up at 1 year and at 2 years. Some people, about half a dozen, their 1 year appointment happens to be around now, and many of them are having a hard time with that. Those, of course, who are in Chicago, we will accommodate them. Those who are from outside Chicago area, we will work with you as soon as you are able to travel, so you get your yearly meeting. And we have a allowance within the design of the study that if this follow-up is delayed a little bit, it can still be done and the results will still be valid. So you stay on. Please keep taking the medicine and the placebo. You will be hearing from Christina, like before, asking you what you're doing and how you're doing. We still want you to take pictures and send us the record of your drug, taking the drug. If it is easier to send it by email, that is fine, and you can later catch up and send us actual paper copies. Christina and Agnieszka, is there anything else on the actual mechanics of the trial that you want to make sure people know about?
Yeah, just to touch on submitting the bottles and the calendars after each month. For those of you who didn't see the email that I sent maybe 2 weeks ago, so instead of having to go out to a FedEx facility to send it, for now we are accepting pictures via text or email to the study phone or the study email address of the calendars and the bottles and any extra pills. But please keep in mind that we do want you to save all of that stuff so that, when you're more able to go back outside, that you can physically send them still. Yeah.
And keep taking the medicine. There's
Yep.
nothing wrong with COVID, taking the medicine. All right, Agnieszka, anything at your end?
No, I think Christina covered all. It's the most important. We still want to hear from you and see what you're doing and how you're doing, and please save it, like she said, so we'll get it later.
And those of you who call us, it's the same. You'll hear from us within the day. you know, that is, we're not closed waiting for something to happen, you know. So we have adapted our contacts thanks to the dedication of the whole team. Our goal is really not to miss a beat. So to make it a little bit more interactive, and we're going to look at other ways to make it more interactive, we of course will have your questions and answers, but did we have a chance to poll the audience? And is it working? I want to apologize on behalf of the team because I brought up this poll thing about 3 minutes before we started. So if we pull it off, it's great.
I think it's working, and I feel like I have to put more than one question on the poll. So I'm just about to post the second series of questions. I've already posted a couple questions, and I'm just about to post the next ones. So keep an eye for them. And if you guys want to let us know in the chat if it's working for you, or if you're seeing our questions, that would be great. And give me 1 second, and the other ones should be up.
Somebody is asking, where is the poll?
Could it be at the end?
Yeah, where it says more. Let me see here. No? I'm also not seeing the poll.
Oh, someone said they answered the poll when they entered. It was just one question. So I think it may have been right when you entered.
Meaning?
Interesting. All right, let me see if it's, so
Someone
we might not see it. Hang on, because I'm getting some text. Let me see.
Maybe another way, let me see the Q&A. No, that's their Q&A.
You can ask people to raise their hand.
Yeah, we can ask people to raise their hand.
Raise their hand is good. We have about 35 people participating, and I think the raise a hand would be very good. So did you want to go ahead and ask the question? Let's try the raise a hand thing.
Sure. All right. So all right. So let's
ask the first question.
Let's ask the first question. The first question is this your first time participating in one of the Atorvastatin clinical trial webinars?
So if it is your first time, raise your hand. How about that?
Perfect.
We only want the hands up of those who are joining us for the first time in one of these webinars for the trial. Are you seeing hands?
I'm seeing hands. I just figured out how to do that.
Okay, that's good,
yes.
because you're better than me. I don't see no hands.
It looks like we have 13 raised hands for that question. 13.
That's good, actually, because, you know, our goal, the reason I'm asking those questions is so you understand, our goal is to have enough of you that we're answering questions about something you're already aware of, but you have additional questions. But we also want to bring new people in. And those of you joining for the first time, I encourage you to put in whatever specific questions you have and what made you want to join. Put those as questions, and we will get to them in the Q&A. So please enter your questions. We welcome you as new people. What's the next?
So just a reminder, at the bottom, there's a Q&A button you can push. If you can put your questions into there, that would be really helpful for us when we go to do the Q&A section in a little bit. All right, the next question.
Before you ask, everybody just put your hands down.
Thank you.
Good idea.
All right. All right, most of the hands are down. Okay, so we're wondering how many people have had a symptomatic hemorrhage?
So raise your hand if you have had a symptomatic hemorrhage in the last year. Just in the last year, you think you had one or you know you had one, raise your hand.
All right, hands are still raising. And it's like we're at 13 again.
Okay, that's good. That means these are individuals who could potentially be candidates.
Yeah. All right, if you guys all want to
lower your hands,
unraise your hands. All right.
What's the next question?
The next question is, are you already involved in the Atorvastatin clinical trial?
So involved, what we mean, you are already been evaluated for the trial, or you are enrolled in the trial. Raise your hand. So raise your hand only if you are already in the trial or have been evaluated by us for the trial.
We have 5. Let's see if anybody else
That's good. These are
jumps in. Yeah.
people who have been already in it and may have some questions. So those of you who are joining, who are already in the trial and you have particular questions we didn't answer, please enter them. We welcome that. And any, what was there any?
I think we have one more question. So if everyone wants to lower their hands. The last question was about whether or not an app would be helpful. So if you were participating in a study like this, would an app be helpful for engaging with the study? I don't know if you guys want to talk a little more about that.
Yeah, so basically we're thinking about developing an app that will allow you, once you contact us about the cash, I don't think it's you know, it is an app before you get involved, but once you contact us and we evaluate you and you are part of the study, then it will be a type of app whereby you can ask questions, you can enter data about your symptoms, what you may be feeling, and it will give you reminders about when your labs are due, when your report of the pills are due, when your next visit is, and those types of reminders. If you were involved in the study, or you imagine yourself being involved in the study, can you raise your hand if you think such an app will be helpful to you?
A lot of people seem to think an app will be helpful. We're at 13 so far, and I'm wondering, and maybe you guys can tell us in the chat if you know how to raise your hand. We maybe should have gone over that, because I don't think I know how to do that. All right, that we have.
I think
10
we're
people.
good. I think this was a good try for the first time, but this is not a statistically valid sampling. We're not gonna cut you out of the U.S. Census because of the answers. So we appreciate you sharing with us some of your thoughts. So I think we should go right ahead and start with some of the questions you've already received.
Yeah, so one of them that was received, what is a trial studying exactly?
Yeah, this is great, and this is particularly useful for the many of you who are joining us for the first time. So to summarize, research over a period of about 10 or more years has shown that leakage of the blood vessels of the brain is what makes the cavernous angiomas bleed. So when you have a hemorrhage in a cavernous angioma, it's because the vessels become even more leaky and they bleed. And this leakage is controlled by a particular signaling or a molecular cue that makes this permeability go bad. So if we can put the vessels back together so they are not as leaky, then the cavernous angiomas will go back to how they were year after year without a bleed. So what we want is to convert the lesion that has hemorrhaged into a lesion that is no longer leaky. And so we're selecting patients who have had a symptomatic hemorrhage, meaning they have had new blood in their lesion. You know, you all hear, I've had bleeding in my lesion, I bled many years ago. Those are not the ones we're selecting. We're selecting patients who have had new bleeding in their lesion in the past year, and there were new symptoms with that bleeding. So let's say you had a bad headache, you went to the doctor, they did an MRI, and they told you, we see new blood in the lesion. And we will help you decide whether this was truly a symptomatic hemorrhage or not when we evaluate you. Why are we studying patients with symptomatic hemorrhage only? To start with, we are studying those patients because someone who has had a symptomatic hemorrhage is 10 times more likely to have another symptomatic hemorrhage in the next 2 years. So of all of us who have a cavernous angioma, most of us will not have a symptomatic hemorrhage in the next year. But if we happen to have one a year ago or less, we are 10 times more likely to bleed again in the next 2 years. So this is probably the most important piece of information I share with you. And that's why we want to identify those of you who have had a symptomatic hemorrhage in the past year, so we can put you in the study, and half of you will get a drug called Atorvastatin, which is a statin medication, the same one used to lower cholesterol, but we are giving it for the purpose of decreasing the permeability in cavernous angiomas. And we have shown that in many, many studies in mice, that the mice that are given the statin will not bleed as much as the ones who receive the water without the statin. So even we can trick the mice into getting either statin or placebo, and the ones who got the statin actually bleed more than the ones who did not get the statin. So the most important thing is to make sure in humans it also works and it doesn't do any harm. And the study is designed to give half the people the drug and half the people a pill that looks exactly like the drug. And then you tell us how you're doing, and we'll check on you and measure the leaking in the brain at 1 year and 2 years and see if you've had hemorrhages or not, and how you are tolerating the medicine. And then at the end, we will be able to tell you and the community whether it is a good idea or a bad idea to move forward with statin as a drug to help prevent a bleed. The one exception that's very important to know is that if your lesion that bled is very easy to remove surgically, sometimes the surgeons will tell you just take it out, and that is fine. However, if your lesion is in a place where it's not easy to take out, or if you don't want surgery, you know, you've recovered maybe from your bleed and you're nervous about surgery, then you could enroll in the trial. And if you happen to bleed a second time, you can still go and have surgery after that. So the idea here is that if you want to avoid surgery, or surgery is not a good idea for you, you may as well help with finding the answer. And also it may help you by being on the better of the two, which we don't know which one. Is it the drug or is it the placebo? So I hope that this was a long-winded answer to that question, but I think it's so important for those of you who have not signed in before to understand that. And for whoever asked this question, you can let us know in your Q&A whether this was a good enough answer for you or not.
Okay, Dr. Awad, I have another question regarding the trial. Are any children under 18 participating in this clinical trial? Is
Yes,
this intended for children?
Right. So the FDA did not allow us to enroll children because the drug is currently approved in adults, and they are not allowing us to enroll children. However, I do promise you that if it is useful in adults, it will be a very, very quick way for the FDA to allow us to test it in children. So the next more definitive trial would then have a case for enrolling children in it. But right now, children are not included in the trial. Somebody, I saw a question down there. Can I cheat and answer it if I saw it? So somebody said, I already take 10 milligrams of atorvastatin, I presume for your heart or cholesterol or a stent. So you are right, you cannot be in the trial. So if you happen to have a hemorrhage, and you are already on statin, then we can follow you like patients who are in the trial, and we have a parallel study called the Trial Readiness study, and it is one where we subject you to the same biomarkers and the same follow-up, and we will count you later as one of the people on statin, and whether you bled or didn't bleed will count. So if you have bled, have had a symptomatic hemorrhage and are on statin, you are eligible to be in the trial readiness limb, But we obviously cannot give you placebo because you're already taking statin. So we will follow you and learn from your case, even if you're already on statin.
Great. One of the other questions was, is there any way to do the MRI required for the trial without traveling to Chicago?
Yes, unfortunately, the answer is no for the trial. For trial readiness, the sites that currently do the same MRI with all the quantitative imaging and QSM are Mayo Clinic with Dr. Fleming, UCSF with Dr. Kim and her clinical team at UCSF, New Mexico at University of New Mexico in Albuquerque, and this is it, correct? Soon to be Johns Hopkins in Baltimore and Chicago. So we're trying for the trial readiness to get these other sites to do the same type of MRI. But the NIH wants us to show that they can do it as well as in Chicago. So that's what we're studying in the trial readiness, but they did not want to open it up to sites that may do the measure not the same way, and then the whole results of the trial would be off. So for now, that you need to travel to Chicago. So that's the bad news. Do you want to hear the good news? So the good news is that we pay you $500 to help you with the trip to Chicago. You get to see us and go to the museum. That's another very good news. You get to have the best doctors in the world look at you and the best nurses and coordinators. So it's not the end of the world, and we'll get you in. And it's only 3 trips, 1 trip to enroll, 1 trip at 1 year, and 1 trip at 2 years. And you can keep your same doctor. So if you have a doctor you like in Cincinnati or in San Francisco or whatever, they probably would encourage you to come. We will do the studies and we will keep you with your doctor throughout the trial. So you don't have to change doctors. It doesn't cost you anything. We don't bill your insurance or anything. So the trial costs are all paid for. The MRI for the trial is paid for. The only time you get billed for insurance is if you ask to see me as a doctor in a consult. But if you're keeping your own doctor and just coming for the trial, Christina will work with you on that. So you don't even see a bill for anything. All the pills are free. The MRI is free. The trip gives you $500. We can even give you a voucher to have a pizza on the way back. All right.
So how will you notify people waiting to get to Chicago that it is now safe to travel there?
Correct. So it depends where you live, whether it's safe or not, right? So if you're in New York, you know, Chicago is a haven. You know, if you are in a place where there isn't too much COVID, I wouldn't come to Chicago right now. And we will advise you on that. So what we want to do is have you contact us. We will use this time to evaluate your readiness for the trial. And if you are a candidate, as the minute we open up and things will become better we're near the peak. So 2 weeks from now, things will be better than they are now, and you'll still be eligible. So basically the way we will say it is take a little bit of a medium outlook on this, and we'll get you in as soon as we can. We'll do 2 a day, 3 a day till we get caught up.
Great. And then is the trial also for people who have the familial multiple angioma?
Yes. So as long as you have had a symptomatic hemorrhage. So the name of symptomatic hemorrhage is CASH, cavernous angioma with symptomatic hemorrhage. That's where the money is, CASH. That's because these are the people most likely to rebleed again, and those are the people we want to test first. You are like the frontline fighters, and if the Atorvastatin works in you, everyone will take it.
Great. So I have some more personal questions. Could my husband's, and excuse my mispronunciation here, arachnoid cyst be related to his CCM3, or is that a separate congenital formation?
Yeah, so we looked at CCM3 in great detail. CCM3 are very special people. They have a unique mutation that is much more aggressive than the other familial cases. So of the familial people, those who have CCM3 are more likely to have more lesions in the brain. They're more likely to have had earlier bleeds when they were children. And they're more likely to also have things like scoliosis, which is an imbalance of the spine, or even brain tumors. Arachnoid cyst was not one of the things that we saw as a group in the CCM3. So I would think it is just a chance that you have both an arachnoid cyst and CCM3. But if we end up seeing many people with arachnoid cysts, we can change our mind on this. But we saw, I think, the most people with CCM3 of anyone in the world, and it's a very rare disease. But thanks to the CCM3 project that the Angioma Alliance sponsored, you get sent to Chicago and we get to see you and go over you in great detail if you have CCM3, and we get to know what the CCM3 community looks like. So we know a lot about you, but I think arachnoid cyst, I would say it's by chance. It's like being left-handed or blonde or whatever. So it can happen and still have CCM3.
Okay, so another personal question. I was diagnosed with a 6mm cavernoma on my right parietal lobe. Could my other symptoms of faintness, neuropathy, tingling, weakness, shivering that I cannot stop occasionally, and word muddling be related to my cavernoma?
So Christina, you get many calls like that. So how do you handle that?
Yeah, so I mean, it could be. We would have to look more into where exactly the lesion is, and I would obtain some of your past medical records, and then we would ask you to send in the actual disc of your MRI so we could go through and see if your symptoms actually correlate with any changes in the lesion.
So lesions in some parts of the brain can cause these weird symptoms. And just because your doctor initially didn't put it together doesn't mean it's not caused by the cavernoma. So we will help you with that. And this is part of seeing a center of excellence or a clinical center doctor who knows about cavernomas. So if you haven't seen a doctor that knows about cavernoma, I encourage you to seek somebody, Mayo Clinic, our team, somewhere that really know about cavernoma, and they can sort that out for you and help you understand. Now, more dangerously, seizures can have those types of symptoms. So what we call partial complex seizures, they can be staring spells, they can be anxiety spells, and it's very important for us to diagnose the problem as to what your symptoms really are. And finally, I do want to also hold your hand and tell you sometimes just having a lesion in the brain can cause a lot of anxiety, and you can end up having all kinds of symptoms and be nervous and be anxious. And we'll help you with that too, because we can tell you that your lesion has not bled, is not causing these symptoms, and therefore maybe treat your anxiety, or your anxiety will go down when you hear that.
Okay, I have seen that many anti-epilepsy drugs have been described as causing some degree of immunodeficiency. As many of us take those, is that a concern should we contract COVID-19?
Yeah, so you have to look at risk and benefit. COVID-19 is so contagious that I wouldn't count on if you weren't on your seizure medicine, you're going to resist the drug. So, so there is no question that you are as likely to catch COVID-19 through touch or through the breathing and through the droplets, whether you are or are not on the seizure prevention medications. The opposite side of this is that if you were to stop the seizure medication and have a seizure, this is probably the worst thing that can happen in the middle of a COVID illness. So if you have a COVID illness and you have an active seizure, now your brain is permeable, your breathing is affected because of the seizure, and you are far worse off than what Keppra or Dilantin or whatever may or may not have done to your immune system. And I want to tell you one last thing. Having a little immune suppression may be actually good for your cavernoma, and it may be good for the COVID. You know, in fact, if you look at hydroxychloroquine drug, It is called Plaquenil. It is an immune suppressant that is used for lupus and other conditions. So that drug may actually end up being helpful in the COVID-19 treatment. If you ask Mr. Trump, he thinks it's helpful. We think it's probably helpful, but we have to study it. But I think at the end of the day, what I'm trying to say is that you cannot over-interpret these subtleties. There are many things unknown about COVID-19. And if you try to over-manage it, you might be doing more harm than good to yourself, and then just going with the flow and following the guidelines and avoiding getting COVID-19.
I would imagine it's the same answer for these questions with the atorvastatin and the immune system. Is there any concerns related to COVID-19?
Not at all. In fact, I'm not supposed to say this, but I'm going to go ahead and say it. So the same pathway that makes you bleed in a cavernous angioma that statin helps also controls permeability in the lungs. So it may end up being that those people who are on this dose of statin actually resist the pulmonary effects of COVID-19. So we have absolutely no hint that it is harmful, but it could end up being a helpful thing. So this is a segue for us to tell you about the registry of COVID-19 and cavernous angiomas. So let me go ahead and tell you about that. Can you raise your hands if you know already about the registry? Those of you who know how to raise your hands, all 13 of you. We have 40 participants. So how many raise their hands if they know about the registry?
We're getting up to 20.
Here we go.
So we got lots of people know how to raise their hands. Now we're at 22.
And lots of you know about the registry. So the registry, you go to angioma.org/COVID, COVID, and you are going to read about the registry, and the registry will not allow people who are nervous about COVID-19, will not allow people who are afraid of COVID-19, will only allow you to register if you have had a positive test. Okay, I know many of you are not getting tested, and you may have it and not know it, and we know all of that. But we are interested in people who have had the test that shows you have COVID-19, and then you can put your name and number if you want us to call you back. We will be calling you back and enrolling you in a study where we ask you questions on the phone. May take between 15 and 30 minutes on the phone with you. And as a result of that, we are going to answer the question whether you are worse off when you get CCM and COVID-19 than other COVID-19 patients, and whether COVID-19 does anything to your CCM. So we will have those answers thanks to you engaging us. So we don't want anyone in the angioma community to have COVID and not tell us. So let's work with you, and we will learn and educate everyone about these questions everyone is worried about.
Great. So the next question is, if I'm already taking atorvastatin for cholesterol, can I participate in the study?
Yeah, so I answered this a little bit earlier. The answer is you cannot enter the atorvastatin trial where you get statin versus placebo because you're already on statin. But we can enter you in what we call the trial readiness study, which is a study in which we monitor you the exact same way. So you're already on statin, so we're not going to take you off and put you on a sugar pill. So we will keep you on statin, and we will follow you with the same measures that we do people in the trial, and you will help us get the answer whether statin is useful or not. So yes, call us. And if you have had a symptomatic hemorrhage in the past year and you're already on statin, we will welcome you in the trial readiness aspect, but not in the trial. And the advantage there is that if you live closer to Mayo Clinic or UCSF or Albuquerque, you can go and have your trial readiness there.
Can you tell us about the MRI machine the study is using? Is it different than the MRI I get locally?
Yes, so there is an advantage to having special MRIs for cavernous angiomas in general. Those may be obtained locally, and if you currently cannot travel, and we want a good MRI, we'll tell you specifically what to get. So these are called 3 Tesla, which are a higher field, and they have to have sequences that detect the tiny little bleeds, and we call those SWI sequences, susceptibility weighted imaging, SWI. So if you can have those done in the community, it's better than the regular jack-in-the-box MRI. They both cost the same, but the good one gives us more information. However, what those MRIs do not do is they do not allow us to measure how much leakage you have in your cavernous angioma, how much actual leakage, and we call it milliliters per 100 grams per minute. It's a very special measure. And also, it does not tell us how much iron you have in the lesion, in parts per minute, you know, so this is parts per million, sorry. So this is really a measure quantitatively of how much iron there is. Why is that important? Because we're measuring that in people who are on statin and who are not on statin. And if statin does you good, it will have less iron at the end of the study rather than more iron. If statin is doing harm, you will have more iron and more leak in the lesion. And we're measuring that scientifically. Unfortunately, for that, you have to come to Chicago right now.
Yeah, so one of the next questions is, any side effects of atorvastatin I should worry about?
Yeah, so atorvastatin is one of those drugs that has been used in millions and millions of people. It has been studied in clinical trials that have involved almost 40,000 people receiving placebo versus statin. So we know a lot about the side effects. The most common side effects are pain in the muscles or feeling tired. Okay, and as it turns out in the trials, as many people who took placebo also had those symptoms. So that basically, you know, just being on statin, you read the internet and whatever, all of a sudden you start having some pain in your muscles and some feeling tired and so forth. But in general, this can be caused by statin. Some serious complications happen very rarely, less than 1 in 100 cases. Will have things like muscle pain that is actually dangerous, meaning you have to stop the statin because of it. So if you have muscle pain and you are in the trial, you call us and tell us, just like if you're taking it for cholesterol and you have muscle pain, your doctor wants to know. The other thing that it can do is if you have liver problem, it can make the liver problem worse. And so we test you very closely for things like hepatitis, for other problem, alcohol, liver disease, before you even start statin. So we even are testing you for the trial more than your regular doctor would do before he starts you on statin. So we will watch you closer than a hawk, you know, for side effects. And we want to learn about side effects. So if you tell us you feel something, we will note that, and there is somebody watching. Are more people complaining of that when they are on the sugar pill or when they are on statin? And we will, if the side effects are so bad that you want to stop the drug, we'll have you stop the drug. You know, so that's kind of where we are. So there are possible side effects. You can read about them on the internet and go crazy, or you can tell us about them and we'll watch them with you and work through it.
And the atorvastatin reduce the size of the CCM?
So it reduces the amount of bleeding in the CCM. We do not know yet whether it shrinks CCM or not, but that is one of the measures we will learn in the trial. In the mice, it did. So in the mice, they had smaller CCMs when they were on statin than on not statin. But we will not know that till we have 40 people on it, 40 people off of it. That's what the trial calls for.
Can an intense coughing fit cause a CCM to bleed?
So it has to be pretty bad. You know, it has to be pretty bad. So if you strain very heavily, like you've never lifted weights and you go to the gym and do the 250-pound thing, yeah, you could bust your CCM. Okay, I cannot rule that out. But for any one of these, there are thousands of you that go to the gym with the CCM and are fine. Okay, so it has to be a pretty bad damn cough to make you bleed.
Is there any evidence that I should stop eating baked goods and ice cream, the emulsifiers?
Okay, what do we tell them, Christina, about emulsifiers?
Stay away from them.
Right. So in mice, when we fed them regular food and then the other group got regular food plus emulsifiers, they bled like a sieve when they were on emulsifier. Okay, their cavernoma bled a lot. So that's because the emulsifiers change the gut microbiome in a way that drives bleeding. So we want you to stay away from preservatives that prolong shelf life of food. So get the fresh food, the organic food, get the Greek yogurt, not the one that kind of stays like plastic for the next 5 months. Don't get that. Okay, so get the stuff that separates, you know, doesn't need anything to keep it together. So that's healthy. And do not try to outsmart your microbiome. So do not go and take like a whole bunch of probiotics or antibiotics or whatever to make my microbiome better, because you may be inadvertently letting the bad microbiome take over. Okay, because you don't know which bugs are good for CCM or not. And we are trying to sort that out for you. And the more we know, the more we will tell you. So for now, avoid emulsifiers.
So I have somebody here who had a bleed last fall, and they have their cavernoma, the right temporal lobe, has been intermittently bleeding for about 4 months now since the first bleed. They've had possible seizures and daily constant headaches due to it. Would you recommend the study, or they should try to get a second opinion for laser ablation?
So for bleeding, we don't recommend laser ablation. So laser ablation does not take away the cavernoma. Laser ablation is good for seizures. So if the cavernous angioma is small and has not been bleeding, but has been causing seizures, then laser ablation is a good option. But if the cavernoma is bleeding actively, meaning you had 3 or 4 new bleeds, the best solution is to take it out, actually, not to get laser ablation. Laser ablation will end up triggering a new hemorrhage and you'll be worse off than you were before. So we deploy laser ablation for seizures, not for bleeding. Okay, for bleeding, the best solution is to take it out. If you don't want to take it out, try the trial while you wait to decide. So, and if you bled 4 months ago, you're still eligible for the trial. But it bothers me that you've had actually several repeated bleeds in a right temporal lesion. The case like that, actually, Christina will put on my surgery schedule before I meet you. That's how we basically, I'll meet you and we'll talk you into taking it out.
Okay. Do you provide the initial MRI to see if you had a recent bleed?
We don't need to come to Chicago for that. So we will use your MRI if you've had one. So usually, if you think you've had a bleed, that means you've already had an MRI or a CAT scan that showed new blood and you've had new symptoms, right? So you send us that study, the MRI or CAT scan. We will review it, Christina and I. And if we agreed we see new blood with your new symptoms, then you don't need another one to tell you you've had a hemorrhage. The next one will be done for the trial. So you may just come and do the trial. However, if we're not sure, this happens a lot. So basically, you got an MRI and one doctor told you you bled, but you're not really sure. That doctor never seen a cavernoma before, and you're not really sure if you bled or not. Then we can help with that. You just send us the MRI and we will help tell you if you really had a new bleed or not, because we can tell. If it's new bleed with symptoms, we can tell and we'll tell you. Worst comes to worst, you haven't had yet an MRI, but you think you bled, then go get one and send us a CD and we'll look at it and we'll tell you.
Okay. Could you explain more about the partial complex seizures, especially about the anxiety spells?
Yes, so partial complex seizures are defined as seizures that have complex symptoms. So they are not the usual tonic-clonic where you just have the shake and lose consciousness. That's a generalized seizure. Partial complex seizures, you don't lose consciousness, you lose awareness. So you basically blank stare or get very anxious and maybe do some lip smacking like this and look up and then come back. Okay, and it may last only a few seconds. So you didn't really lose consciousness, but you lost awareness. And sometimes a panic attack can be like that, right? So people can have a panic attack, they can feel big anxiety coming, and then a few seconds later, they're okay. So we will work with you to try to understand if this is an anxiety attack, a panic attack, or an epileptic spell, and it may need an evaluation with an EEG and a specialist in epilepsy that will help me reach that decision. So don't self-diagnose yourself. If you have symptoms and the cavernoma, it's important to get to doctors that can sort out whether those symptoms are caused by the cavernoma or not.
Okay, how long until we are able to take atorvastatin as a result of the trial if the outcome is positive?
Yeah, so this is almost like standing behind Mr. Trump and telling you whether to take hydroxychloroquine. So I'm gonna give you the scientific answer is that if the trial shows that atorvastatin is bad, we can tell don't ever use atorvastatin. So that answer will be definitive. Nobody will do another trial to tell you it's bad. So if we find signal that atorvastatin is bad for you, we will be serving the world community by telling you don't take atorvastatin. Okay? Now, if the opposite is found, meaning atorvastatin shows all the signs that it's helping, then we need typically to do another study called the phase 3 trial. This one will be done at many hospitals throughout the country to really show that it in fact stops the bleeding. Because we're measuring the biomarker, the iron effect, the permeability effect. So we may see benefit in that, but not have enough numbers of bleeds to tell you that it really decreases bleeding. So it is very likely that we will do a phase 3 trial at many, many hospitals, at like 30 or 40 hospitals. So it will have more patients and it will be quicker to get the answer on the bleed, probably within a year, a phase 3 trial. Now, what happens in reality in a drug that's already approved and can be prescribed by any doctor off-label, it will be very hard to prevent doctors in America from writing you a prescription if our trials showed a lot of benefit. Okay, so we could do both, right? So some people can participate in trials at big institutions like ours and Mayo Clinic and whatever, but you know, I couldn't fight your doctor if they decided to prescribe it if we showed benefit. But right now I can fight your doctor because I don't know if it harms. So don't take it outside the trial unless you're on it for legitimate reasons for your heart and cholesterol.
Great, we have another personal question. My husband, since a child, has had hemangiomas on his skin and tongue, as well as many cavernous angiomas in his brain and spine. Is it common for patients with cavernous angiomas to also have skin lesions, hemangiomas?
Yes, so you have the familial form of the disease. So, you know, we have two clubs in the angioma community, the solitary club and the familial club. The fact that you have multiple lesions in the brain and lesions on your skin and tongue means you have the familial form of the disease. So the most important thing is to get to a team that knows what that means. Meaning doing genetic testing to know whether you have CCM1, 2, or 3, know whether you got it from mom or dad, you know whether your brothers and sisters or children are at risk for it, and so forth. So that's very important. But yes, if you have the familial form of the disease, about 15% of the patients will have skin lesions. and it's a little bit more in the CCM3 group. So you may have CCM3, you know, and then we'll see. There are other syndromes than cavernous angioma that have skin lesions and other problems in the brain, like hereditary hemorrhagic telangiectasia. You may have heard of that. Now they have AVMs, they do not have cavernous angiomas. So we want to really be sure that what you think are cavernous angiomas in your brain are actually cavernous angiomas, because you may have AVMs and you may have a different disease. So it's very important to get to a doctor that knows the difference between the two. And guess what? If you go to a doctor that gives you a blank stare, then go to another one. Okay, no blank stare. They have to know what they're looking at.
Are there any tools and help for patients who have insurance but no doctors who specialize in CCMs are in the area?
Yeah, so we try to work with you, right? And the Angioma Alliance tries to work with you. So we're developing clinical centers as well as centers of excellence. And you know, yesterday we interviewed another center that will become a clinical center in Miami, for example. There is one in Virginia. There is one in Boston. There is one in Cincinnati. So those are centers that have met the minimum criteria of knowing about cavernous angioma. It is well your worth to get to one of them. Of course, if you want to go to a higher level, the centers of excellence that offer a lot of research and so forth, there is a handful of those. For children, it is Children's Hospital in Cincinnati and Boston. For adults, it is UCSF, Mayo Clinic, Chicago, and New Mexico.
Okay. Somebody wants to know if they can register if they had a negative COVID test but positive for the antibody.
Yes. So any test that is positive for COVID, please register. And you will see one of the questions we will be asking you is what kind of test you had and so forth. So yes, any positive COVID test, rapid test, antibody test, anything. We need to have one positive test in order to include you in the study. Then we'll sort the rest of the details with you.
Okay. A personal question. My daughter has 162 CCMs in the brain. She had a T3 MRI for a possible clinical trial with propanol. She had 12 focal seizures within 2 days after the MRI. Why is this? When the next clinical trial comes up, she can't do the T3, but she can do the MRI 1.5.
So I cannot imagine why the T3 MRI would cause seizures. There is no basis for that. We have epilepsy centers that use 3T on epileptic patients all the time. We even use 7T and 8T, and they've never caused a seizure. So I suspect it's either a reaction to the gadolinium, so maybe the gadolinium dye caused the seizures, and you could try your MRI without gadolinium, but on the 3T. Or it could be some other thing going on. Maybe the reason you had the MRI is because you were having seizures and then you had a cluster of them after. So I think that the MRI, you know, I'm not your doctor, so, you know, you can take my whatever I'm saying for whatever it's worth, but I do see more cavernous angioma patients with seizures than probably anyone in the world. So I would know a little bit about that. And our answer would be that it's not the MRI, and let's dig into another answer as to what happened in your case. And I'm really sorry about living with so many lesions. And there are many people like you and many people who actually do fine with that. So, you know, don't get discouraged, and go to somebody that sees a lot of patients like you. Those big centers all do, and we will take you in and join the club. There are many who have even more lesions than you and they're doing fine. So we'll try to get you there.
So another personal question. My son's cough is so bad we had to go to pulmonary doctor. They just gave him an inhaler with a steroid. What do you think about that? His cav is not operable.
It should be fine. So The worst thing that would happen is to have low oxygen and bad asthma that's not controlled. So that can be bad for cavernous angiomas. Steroids are fine. Anything you do to get that asthma under control or any other breathing problems under control will be better for the cavernous angioma. The brain likes to have oxygen and doesn't like to have problems with the breathing.
Okay, so another question. A heavy left frontal lobe CCM. It was discovered incidentally, no symptoms. It is 3 centimeters and stable. Due to COVID, I missed my yearly MRI. My neurosurgeon said we can wait until this pandemic is over. We are just monitoring it as it has never bled. Do you agree to just monitor an asymptomatic lesion?
Yes, I would monitor it if it's asymptomatic. Just make sure it's asymptomatic and you don't blow away some symptoms like anxiety attacks, that could be seizures and things like that. But if really it hasn't changed, it remains absolutely stable on multiple MRIs, we would also advise you to skip this MRI until the corona thing is over and then have your MRI. There is an advantage to monitoring it rather than forget about it. So maybe we talk for a minute about that. Christina, want to tell them a little bit why it's a good idea to monitor it rather than forget about it?
Yeah, so we like to monitor even asymptomatic lesions at least on a yearly basis, just because we want to see you and know if anything in your life has changed and if anything with the lesion has changed. And then we can kind of relate the two and see if there's anything differently we need to be doing. But just because it has never bled, doesn't mean that it cannot ever bleed. So that's why we need to keep watching it.
So thank you, Christina. That's really the answer. And in fact, we just published a paper. It just came out this week in the Journal of Neurosurgery called Subclinical Changes in Cavernous Angiomas During Follow-up, meaning you haven't felt nothing, you went and got an MRI, your cavernoma grew or bled, and you didn't even know it did that. So that type of event happens much more frequently than we used to think. And you'd want to know if your lesion is bleeding and you even without symptoms, because who wants that to grow in your brain? And sometimes we look and we find out, oh my golly, I just started to take Botox injections, or I just took something that went crazy with my microbiome, like I started some new probiotics that somebody got me from Iceland or somewhere, and they've been really great. God knows the cavernoma is taking off. Or I just started in vitro fertilization or oral birth control pills or hormone replacement to build my body. And all of a sudden your cavernoma is 3 times the size. So keeping an eye on it will put together what's happening in your life and will reassure you that the lesion is fine, or you may be doing something inadvertently that you didn't know that's triggering this thing. So that's the reason to keep an eye on it. Sorry about the long answer, but I think it's important.
We're actually almost out of time. Joanna, do you mind if we just focus? There's a couple of questions that are related to the trial that we'd like to get to before we wrap up.
Yes, so I guess we'll answer. Can trial participants also participate in the phase 3 trial should it happen?
Yes.
Okay. If the trial proves successful, how long would it take to be approved in Canada?
Oh God, no, I don't know how Canada does. I think it will be the same as here. Usually Canada follows US Food and Drug Administration, and all the drugs that are registered in trials.gov are looked at by regulatory agencies in Europe and Canada. So I think whatever happens in the US will quickly follow in Canada. And I bet you'll get your doctor to prescribe Atorvastatin in Canada if it works in the US.
Okay. Do you see any others regarding the trial that you'd want to ask?
Sorry, any other questions on the trial?
Was there any other ones on the questions I sent you earlier? There might have been a couple at the bottom.
Those were all answered.
Okay, great. I think we're good
And
then.
I see some very nice comments from many of you. Thank you for sending these sweet comments. It makes us feel very good.
Yes, lots of people are saying hi to you.
And
Gabrielle says hi.
So guys, hang in there. This will get through this COVID thing, and we're on your cavernous angioma just the same, and we're gonna try to get the answers. And in the upcoming webinars, hopefully the worst of this is behind us all, and we're back in business big time. Meanwhile, those of you who have any questions about the trial, just contact us. What's the number to contact, Christina?
It's 773, and I can put it in the chat too. 773-326, and then hold on, I always forget.
Isn't it something like @cash? Why don't you give them the email?
Oh, I can give that too, but the phone number is 773-326-9839, and then the email address is @cash, so ATCASH @uchospitals.edu.
So @cash, ATCASH, and then the email uchospitals.edu. And the phone number is specific for the cash trial, so we always get those calls, and within a day you'll get an answer. Often it's more instantaneous than that, knowing Christina, but within a day you'll get an answer, and we're always there for you.
A few people are asking how they can get in touch with you with more clinical related questions and not related to the trial. Is it the same number or different number?
Same number.
Okay.
Same number. You can
Different
also,
number.
What different? No, you can if they say you'll refer it to them. It's the same person who handles
Same
both.
person, sure, yeah. So that's going to make it easier.
Right. And you know what? There is also a website for clinical things. I'm going to give you that. Is uchicago.org, uchicago medicine. So one word, uchicagomedicine.org/CCM. So you go to that, and you will have all our contact numbers to get in touch. uchicagomedicine.org/CCM. And you look us up. Go CCM Awad, CCM Christina. You'll get us on the internet.
Perfect. All right. Sorry we didn't get to everyone's questions. You all were very prolific with your questions tonight. We appreciate it. Thank you for joining us. We try to do these every 3 to 4 months. So we'll see you again probably in the late summerish.
And I want to say thank you to Joanna and Darla for, this can get boring. You guys have the same questions all the time, and you have to put up with us and all of that, but you always show your enthusiasm and you do it. We notice after these webinars that we get several people who are candidates who otherwise may not have reached us. So you're doing a big service. And also, I think the questions and the information has kept people in the trial much more because of this engagement. So we take this very, very seriously because it's part of our strategy to do the study the best way we can and to do other research and to help your questions. Thank you very much. And thank you, Agnieszka and Christina, also for taking your time generously at the end of the day to do this.
Thank you to everyone participating.
Thanks all of you. We really appreciate it.
Bye.
Bye, guys.